everyone, my name is Minjung Cho. I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce APS Hot Off the Press. 2 times a month, we'll be hosting Hot Off the Press with one of the recently published APS authors and 2 panelists. You have a special opportunity to hear directly from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Okay, hello everyone. I'm Kyori Kim, one of the social media section editors of the Archives of Plastic Surgery. For today's Hot of the Press, we have the article which was published in May issue, Patient-Specific Surgical Options for Breast Cancer-Related Lymphedema, Technical Tips. We have Dr. Kwon, who is one of the authors of this article, and as a panel, Dr. Yoo-Jin Myung from Seoul National University Bundang Hospital in Seoul, and Dr. Nicholas Pereira from Workers Hospital in Chile. They'll be with us. First, let's start with Dr. Kwon's presentation, and then the discussion part between the speaker and the panelist will be followed.
How are you, audience? I'm Jingeun Kwon from Armed Forces Capital Hospital, Seoul. Thank you for inviting this paper as on Hot Off the Press. Today, I'd like to introduce the patient-specific surgical options for breast cancer-related lymphedema, technical tips, which was published May issue of Archives of Plastic Surgery. This paper is based on the treatment protocol of Assam Medical Center. In this paper, we suggest algorithm for performing customized treatment for each upper limb lymphedema patient and share our detailed tips for each surgical method. Let's talk about the algorithm first. There is no doubt about the fact that the paradigm shift is made from ablative surgery to physiologic surgery. However, is creating a bypass at the distal limb level sufficient to call it physiologic surgery? Although the pathophysiology of lymphedema has not yet been established, this paper tried to solve the underlying pathologic cause of lymphedema. Our treatment algorithm starts with the LVA. In addition to LVA, we try to find the pathologic cause of each patient, eliminate the pathologic cause, and reconstruct it by like-with-like approach. And most of upper limb lymphedema initiate after mastectomy, so we focus on the axilla. If you carefully evaluate the axilla of breast cancer-related lymphedema patient, soft tissue of the axilla is changed with firm and scar tissue. In addition, there are patients whose axillary continuity is completely disconnected and show muscle-to-skin tightness. Through this, it can be estimated that something is blocked at the axillary level. In some patients, the axillary vein is contracted and narrowed. If the vein is at this level, the lymphatics are bound to be more severely blocked. So let's go into the axilla to eliminate the pathologic obstruction. If you go inside the axilla, you can find the barrier made of scar tissue between the arm and the chest. Therefore, we must completely remove the scar tissue until healthy fat tissue is identified. It is totally different from the scar release. After that, evaluate the size of the defect to choose the reconstruction option. Depending on the size of the defect, we choose the reconstruction option. Let's summarize the algorithm. When a patient with breast cancer-related lymphedema comes, the condition of the axilla is evaluated, and if there is sufficient soft tissue, LVA alone will be enough. If there is a depressed scar in the axilla, perform the scar excision. After that, depending on the size of if the defect is small, such as less than 3 cm, it is covered with local advancement flap. And if the defect is large, such as more than 3 cm, vascularized lymph node transfer is performed with appropriate size flap, which has abundant adipose tissue. Consider simultaneous autologous breast reconstruction if the patient has not undergone breast reconstruction. From now on, I'd like to share our technical tips. The target lymphatics for LVA are superficial collecting lymphatics, which is located below the superficial fascia. Among the superficial collecting lymphatics, ectatic lymphatic, whose function is maintained, are preferentially selected. To find these lymphatics, map them using ultrasonography and MR lymphangiogram. Find the circular and luminal structure which does not collapse under weak compression and collapse under strong compression with ultrasonography. However, at this time, the more hyperechoic, the more severe sclerosis expected, so avoid hyperechoic lymphatics. Among several anosmosis fashion, the site to end the LVA is preferred. This is more physiologic and effective method because it does not break the existing lymphatic pathway. Two lymphatic vessels were anosmosis to vein inside to end fashion. You can see lymphatic fluid are drained through not only the new green pathway, but also through the previous existing yellow pathway. During the vein selection, if possible, maintain the flow of the main vein and use the branch of this main vein. By doing this, lymphatic fluid are suctioned faster through the Venturi effect, which maximizes the pressure gradient. Accurate anosmosis is essential, and for this, the appropriate amount of wall must be recruited. The adventity of the lymphatic wall should be stripped carefully, and it is helpful to use the marker after stripping. For scar excision, we prefer to approach through the previous scar. Find the scar tissue and remove the scar tissue while peeling it along the boundary between the scar tissue and the fresh fat. During this process, care must be taken not to injure the neurovascular bundle. First, find the pectoralis major muscle. By dissecting the space direct below the pec major, you can easily reach the axillary vein. As axillary artery and nerve are located deeper than the axillary vein, dissecting the neurovascular bundle located deeper than axillary vein is not recommended. The perivascular scarring around the axillary vein should be sufficiently removed, and through this process, the vein pressure can be lowered, which is ultimately maximizing the effect of the LVA. Be sure to review the mastectomy operation record because expecting the extent of node dissection is helpful for scar excision. As a recipient vessel, we usually prepare the thoracobursal artery or lateral thoracic system. Preparing the lengthy recipient vessel is important as microanosmosis can be performed outside of the axillary pocket, which is comfortable for surgeon. Our workhorse flap was ski flap, as ski flap can supply sufficient fat and lymph node with minimal mobility. The omental flap was also considered when simultaneous breast reconstruction with depth is planned. 1 to 3 lymph nodes were included in the flap, and the artery and vein connected to the lymph node should be preserved. To prevent iatrogenic lymphedema of the leg, the lymph node located lateral to the femoral artery were usually harvested. This is a paper presented by Dr. Nicholas, which report the improvement of lymphedema by transferring lymphatic vessels according to direction of the lymphatic pathway. So we also follow this concept during our flap harvest and insetting. The distal side of the flap were sent to the arm, and the proximal side of the flap were sent to the chest, which follow the physiologic alignment of the lymphatic pathway. When this inset was performed, the lymph nodes are spontaneously located at the axilla. It is important to prevent the rescarring. For this, quilting was performed so that noded space was created between the flap and the surrounding fresh fat. In addition, meticulous hemostasis was performed to prevent hematoma collection, which can cause the fibrosis of peripheral tissue. Thank you for your attention.
Thank you so much, Dr. Kwon, for amazing presentation. So we have Dr. Myung and Dr. Farah as a panelist. Do you have any questions or comments?
Congratulations for the great research and the great paper. I really enjoyed reading it about all the algorithms and treatments strategies regarding breast cancer-related lymphedema. Actually, I also spent not a long time, but about a week in Asan Medical Center with Professor JP and Professor Peter and John Peck and Dr. Kwon also. As my first question is that how do you measure the severity of the axillary fibrosis? Because like in your paper, the severity grade of the axillary fibrosis is very important for choosing the right method. So how do you, not subjectively but objectively, do you have some grading scales or do you have some other imaging methods other than just looking at the patient's axilla? That's my first question.
Thank you for great questions. We try to make the objective finding for deciding whether we need the scar release or not, but retrospectively reviewed the many cases and we conclude that most of the patients require the resection because when we start this concept at that time, we was hesitate to do the scar release, but when you go in most of case, there was really digestive scarring. So nowadays, we actually try to explore always, and if there is not too much scar, and just we use the advancement flap of the peripheral tissue. If there is a severe scarring, we do perform the lymph node transfer.
Dr. Pereira, are you doing the scar release and excision routinely for the patient?
Yes, first of all, I would like to congratulate Dr. Kwon and his group for this very interesting article and that they emphasize the importance of doing the individualized treatment for these patients. That is paramount in my opinion. Regarding your question about scar excision, I think it's very important. I am doing when I see that it has a role in that lymphedema. Same as Dr. Kwon presented in his paper, when it's scar, it's due to sentinel lymph nodes or it's not that much fibrosis. There is not necessary to do the excision, but if there is an important retraction of the axilla, we all know that at least relieving axillary vein pressure, that gives you more effectiveness of any of your treatments. So if there is also a gap in between after your excision, I think what Dr. Kwon presented is a great option to interpose lymphatic vessels and also lymph nodes flap to give more chance to relieve that pressure and also the lymphedema.
How is your experience, Dr. Myung?
The main reason that I asked Dr. Kwon about scar fibrosis is that in my experience, I pretty much guess that other surgeons experience the same thing, but for the delayed breast reconstructions or plus or minus lymph node transfer on axilla, if we just excise the scar tissues or release the scar tissues, then immediately a lot of vessels just come out. Before the excision of the scarrings, the venous return was very, very, very slow or was very compressed, in other words. But after the scar excision, just all of this small vessels just immediately comes out. We can just visualize the immediate release of this fibrosis and other blockage of the venous return. When I talk about phenomenon with my rehabilitation professors and clinicians, they also think that release of this venous blockage is very essential for post-operative results regarding the lymph node transfer and regarding the lymphedema. But in my practice, in the early stage patients that only do LVA, I try not to just do the additional surgery on the axilla because usually I do it under a local anesthesia or just a light minimal IV sedation. So if I try to do the axilla scar release, then the surgery time will just go longer and the patients will have some more things to do. They will need some general anesthesia. So in my practice, the early stage patients, I don't do the axillary scar excisions routinely.
And if you want to get any objective finding regarding the severity of scarring,
Mhm.
Seoul National University will routinely perform the MR lymphangiogram preoperatively, and they will show the axillary vein status. And some of the patients have already contracted axillary vein at the axilla. Can be one of the objective finding of amount of severity.
Dr. Pera, do you have any question or comment?
Yeah, I have a few questions. If the surgery can be effective in late stages, and you and your group have showed that in other papers, we know that the earlier the better. In your article, you said that patients start with this congestive therapy. And my question is, after how long or when do you think the patient is candidate for surgery?
Only patients come to the hospital immediately after surgery of the mastectomy because they have swelling symptoms and they come us, but we routinely recommend the compression for at least 2 months, intensive compression therapy with the rehab team. So within 2 months, we do not decide to perform the surgery. We always wait for 2 months.
In the same way, in my opinion, the earliest is the best. So do you think there is a room in your algorithm for risk reduction lymphedema surgery or prophylactic lymphedema surgery at the time of axillary dissection?
Actually, our teams are also interested about prophylactic LVA. We participate the mastectomy surgery, so whether there is a leakage of the lymphatics after axillary lymph node dissection. But you know that just few cases inject the ICG at web space and see whether there is a lymphatic leakage at the axilla. In most of cases, it was not that severe. And in case if there is a definite leakage of the large lymphatic vessels, we are agreed to do that prophylactic LVA at that patient. But if there is no definite leakage of the lymphatic fluid, we are not agree with the prophylactic LVA.
Yeah, probably directly related with how aggressive is breast surgeon. So there are more surgeons that has more leakage in, and in that cases, probably it's a good idea to do prophylactic LVA. I agree with you. And in your article, you mentioned the importance of pre-op planning and lymphatic vessels mapping. There is published some papers related to the best location for LVA is the overlapping area between the linear and dermal backflow pattern and the ICG lymphography late phase. So for you, how important is ICG lymphography stages for deciding the LVA location, or do you decide the location based on ultrasound only?
We routinely performed ICG and MR lymphangiogram and ultrasonography, but we don't believe the ICG. Really, early stage patients show the reliable mapping for the ICG, but advanced stage patient does not give us any information about the lymphatic using the ICG. So we are mostly believe the MR lymphangiogram. That is our first main pre-op mapping, MR lymphangiogram, and second is ultrasonography, because the accuracy of the MR lymphangiogram is getting better nowadays. So we are first use based on the MR lymphangio finding, we search that place using ultrasonogram, and we directly mapping the exact location of lymphatics using the ultrasonogram. If the patients are in the early stage, ICG tests give us a lot of information. I agree with that. But penetration of the ICG lymphangiogram is really shallow, so it does not give us any information if the swelling got aggravated.
I want to ask Dr. Myung and Dr. Pereira, what type of pre-op like diagnostic modality do you use in your practice? What are the pros and cons of each modalities?
I do ICG and I also do the ultrasonal. And I do the MR and angiogram due to some practical reasons. We are not doing dynamic contrast-based MR and angiogram. We just only do the non-contrast. That's sort of very static. It's not dynamic. So I really want to do the dynamic MR and angiogram, especially as Dr. Kwon said, for late-stage patients.
Yeah, I do ICG lymphography. I think ICG lymphography for study the function of the lymphatic system And as an anatomical study, to know exactly where the lymphatics are, I do MRL, magnetic lymphoangiography. And that gives me an idea of anatomical findings. So I have both physiological and anatomical findings, and then I decide where to do and how to do the LBAs.
Yeah, I forgot one more thing. We do the 99 technetium-based lymphoscintigraphy by nuclear medicine department. That gives us the whole body image. So that is very helpful, but not specifically anatomic. So it's very hard to just locate or decide whether it's surgery we should do, but it's very convenient to just understand all of the general function of the lymphatics of the limb. Sorry to interrupt. I want to ask Dr. Perret this question you said before about preventive lymphatic LVA, lymphatic reconstruction, immediate reconstruction. Are you doing in your practice right now?
Yes, every time the breast surgeon has an axillary dissection, and I mean not a sentinel lymph node, so axillary dissection, I go, after they do the surgery, I go and perform ICG lymphography. And if I see any leakage in the lymphatics on the axilla, I do preventive LVA in every lymphatic that is interrupted.
Where is the location that you inject on the ICG to check the leakage of the axilla?
On the web spaces.
Not on the breast side?
No, I just want to know which upper limb lymphatics are affected. If you inject the breast, for sure you will see other lymphatic interrupted. But what we want to do is to prevent upper limb lymphedema. And sometimes it's only one LPA, sometimes it's 3 or 4. In my experience, it's very effective.
Oh, okay. To just back up Dr. Kwon's answer regarding the preventive LVAs, and specifically in Korea, it's off-label for now. So we cannot charge the patients, and it's not against the law, but it's just off-label. And there is some many practical issues regarding the preventive LVAs. We know that it will just be beneficial for the patients. So I think the surgeons and super microsurgeons especially should, that there's some work to do, benefit more patients about it.
How is the situation in Chile? Can you charge it?
Yeah, even if there's no so much evidence, there are some groups in Italy and also in the US that has important series published. We based on evidence to show the patients and the insurance that this is an effective surgery for a group of patients. Well, we don't have problem with that.
I have questions about the prophylactic LVA. The pressure of the vein will be higher compared to distal limb at the axilla, I guess, maybe. Can you confirm the exact washout or clear finding after LVA, prophylactic LVA?
Yeah, you're right. If you use direct branch from the axillary vein, probably the vein will have a higher pressure compared to the lymphatics. But you should use venules, very small veins, and if you're lucky to find a valve just after the LVA, it will be very effective. But if you use venules, you will not have reflux.
Dr. Kwon, you said in your center, the skip flap is the workhorse flap. Sometimes you're using Omental flap, right?
Yes, right.
Based on what you choose the flap, or do you have any experience using other flap?
Basic principle to choosing the donor site is it have sufficient adipose tissues and where it has enough lymph node and it has minimal donor site mobility. And at first, we think the SCIF is the best donor site, but when patients are doing breast reconstruction with the DF flap, it is hard to harvest SCIF flap from one side because if we harvest the one side of SCIF, and then post-op scar will be distorted. As this paper said, we usually harvest defect layer of the SCIF flap at only time, but we changed our plan to use the augmented flap because to perform the DF flap, the patients have to make long scar and abdominal scar, so there will be no any more mobility after harvesting the augmented flap. So we choose our strategy to use the augmented flap when the patient use the DF flap. Professor Hong sometimes use the submental flap or supraclavicular lymph node flap. We are not familiar with that flap yet.
Dr. Myung, APS, you published about the Omental flap.
I saw that too, yeah.
Can you share about that?
That paper was about reconstructing the lymph node transfer with mental flap with LVA simultaneously. I performed LVA during the harvest of the general surgeon's mental flap harvest with laparoscope, so we could save time. That was my main message of that. There's a multidisciplinary approach to the patients. Saved us a lot of time because for the breast cancer related lymphedema, it's very easy to just do the multi approach. In my practice, I'm not using gradually the incidence of the using omental flap is getting smaller and smaller because in my experience, my long-term aesthetics regarding the omental flap is not, I think it's poorer than the skip or DF because like the fat, the characteristics of the omental flap is very different from the subcutaneous fat that we are familiar with. We just have to see the long-term results regarding the omental flap and skip, simultaneous DF plus skip, and there's so many options regarding it. I'm just trying to do the various ways for the patients and waiting for this long-term results to come.
That's interesting. So Dr. Kwon's practice, like the trend is try to more use the omental flap, but it's reverse in Dr. Myung's practice.
In breast reconstruction part of view, using the skip simultaneous is very difficult to inset the DAP. And for lymphedema super microsurgeon's point of view, it's very important for the skip to just go in the right place. There's a lot of options going on. I don't think that there is a one correct answer. We should definitely try some other things that for the patients right now and wait for the long-term results, I think. I am very curious about Dr. Pereira's situations right now.
Yeah, well, my first choice for a lymph node transfer is gastroepiploic lymph nodes. Smaller than the omental flap, it's all the lymph nodes that are in the great curvature of the stomach. Why do I use that? Because first of all, the risk of donor site iatrogenic lymphedema is almost zero. And also you can divide the flap in two different flaps. So when I need, I just do the insert in the axilla and another insert in the distal arm. So that's why I prefer doing gastroepiploic lymph node transfer.
Anybody of you have more questions?
Dr. Nicholas, and I wonder about the long-term outcome of gastroepiploic flap at the axilla because our concepts are making the fat tissue, connecting the proximal fat margin and distal margin using the flap. And Dr. Myung say that long-term absorption of the fat is different between skip flap and omental flap. We also worry about maybe we don't know about the absorption rate of the omental or gastroepiploic flap. How was your experience in the long-term outcome? Is it the flap on the axilla are maintaining their volume, or is it too much decreased than our plan?
In my experience, it doesn't get smaller and harder. I do remember one case, but it's a lower limb lymphedema, that the flap didn't succeed, and finally it's fibrotic tissue, and you can see that it's not a supple fat tissue. But in the axilla and also in the distal arm, if the flap is viable, the fat and lymphatic tissue, it's almost the same. In this, we are talking about lymphedema arms. So the skin of that lymphedema and advanced stage lymphedema is not as supple as the normal skin. So very similar to the other fatty tissue.
Okay, thank you so much for joining Hot of the Press. I think our discussion was very interesting because we can compare two different practices, even in the same country and between Korea and Chile.
Thank you very much. Stay healthy.
Stay safe.
Thank you everyone for joining us this fantastic discussion. Be sure to tune in for the other article that we'll be discussing on this month's Hot of the Press. You can also connect to Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We're looking forward to meeting with you on our APS social media. See you soon.